now going to start our session this afternoon with our very interesting panel where the audience can ask any question they want to the speakers. We're going to use this microphone over stage left, over there. So if you have a question, you can filter to that side of the room. And it can pretty much be any question, but it has to be, actually a tight question. If you have something specific that you need to talk to about these doctors, I'm sure they would be more than welcome to sidebar with you after, like if it's a specific thing about your condition. But we want to be able to just be as informative as possible, covering any topic, any kind of cancer that you want to bring up, anything that's on your mind. And we have a great group here. John Malanca and Sean Devlin are going to be moderating the panel. Dr. Sean Devlin is going to be moderating the panel with John Malanca, Dr. Goodyear, Dr. Stroup, and Dr. Winkler. So welcome, everybody. And
you forgot Dr. Connealy on the screen there.
Oh, she's here. Dr. Connealy. Hi. Dr. Connealy's coming in by Zoom. Thank you so much for being with us. So you guys are going to have to moderate to Dr. Connealy. All right, thank you.
So thank you, Julia, and thank you, panel here. This is always a fun discussion because when we leave these conferences, a lot of questions that are unanswered, and so we wanted to have this panel so we don't have something set up, but we wanted you to ask the questions, and that's what the Appleseed project is about, as well as Best Answers for Cancer, is being able to approach these doctors who specialize in what many of you are going through. And so please ask any questions you may have. This is your time as well. Dr. Connealy is live from California. I don't know if you can see me, but hello, always great to see you. So you want to start with, she's in the middle of her practice, in the middle of her day as well. So if you have any questions, let's throw them out. I do have some questions here. Does anybody have any questions that they want to start with? You've heard all these speakers here, except myself or Dr. Devlin. Is there anything that stands out, or do you want me to read question? Yes. So these are the breast cancer goddesses, and I met them at lunch today. So please.
Yeah, so.
Oh, not on.
Let's see.
Okay. You're
yes.
No?
Am I on?
There you're on.
Can you hear me?
Go. Thank you.
Okay. I know Dr. Tracey spoke a lot about the peptides and immunomodulating medications. What about the role of low-dose naltrexone comparison to peptide therapy?
I'm going to let someone else answer. It's not my scope, but I do like low-dose naltrexone. I have nothing against it. I think it does help modulate inflammation, especially if they're not doing, I think it's over 6 milligrams. But it's been new in the last year that a lot of people have been introduced to it. But keeping inflammation under control obviously is good because you have to be functional, but you have to get to the root as to why it's being created. But if someone else wants to chime in.
It's a lot.
Yeah, I think, low-dose naltrexone is kind of that flagship as a immunomodulator, as a repurposed medication. But I think it's important to understand that there's a massive number of nutraceuticals, repurposed medications. I mean, low-dose metronomic chemo is immunomodulated. So we have to understand that process doesn't just apply there. And, ivermectin is a great immunomodulator. Mebendazole is a great immunomodulator. So they all have their role there. And when you look at immunomodulation, and when we talk about inflammation, I think inflammation is that word that gets thrown out there a lot. And it's like, no, inflammation's our friend. I mean, if you go out there and get a paper cut, you recognize the benefit of that. But what cancer does is cancer creates nothing new. It disrupts everything and misuses everything. It's a great adulterator. So it's going to take all that inflammatory signaling and misuse it. And so we have to recognize that process and how that's working. So as we try to modulate the immune system, what I always say is the cancer doesn't just wave the white flag and say, oh, you got me, I give up. What it's going to do is it's going to try to modulate back. And so the more we can better understand how that process is working, whatever immunomodulator we're using or therapy or method, and we just have to be able to monitor that and be able to pivot in real time as much as we can.
Great, thank you. Here's a written question. If you have any questions from the audience, please write them in. This is a PSA question. I've had a good PSA number for the last 1.5 years, 1.1 to 2.2. Last month, my number shot to 6.6. What could cause that, and do I need to take any action?
Dr. Connealy.
Dr. Connealy, did you hear?
Yes, it was about the PSA. It was 1.1 to 2.2, and then it went up
Yes, to 6.6.
to 6.3. Okay, well, first of all, PSA is not something that you use absolutely for diagnosis, and I'm not sure how old the gentleman is, but depending upon age, PSA can go up. But PSA number is not the definitive guide to whether you have cancer or not. So what you need to do is you need to partner with a physician who truly understands how to use the PSA, how I use it in my practice. If I see a patient annually and their PSA is always 1 and then it goes to 2, I know we have a problem. And so every individual is an original. And so the doctor seeing you needs to do really extensive testing, looking at PSA, looking at PAP, prostate acid phosphatase, along with your hormones, estrogen, testosterone, dihydrotestosterone, looking at a comprehensive look. Never use just the PSA. Also, imaging would be very helpful, doing an MRI, or you could do a color Doppler ultrasound. And so people can have elevated PSA and not have cancer, and they can have an elevated PSA and have cancer. So you've got to not use the PSA as your guiding light necessarily if something is wrong or, pathological. So there's so many things you've got to look at with a patient besides just PSA.
Thank you, Doctor. And while I have you here as well, what test do you recommend after finishing chemo and before starting metabolic approach while NED? And this is a high-grade advanced ovarian cancer. Another question to you, Dr. Connealy.
Yeah, what was that question, John?
Sorry, what test do you recommend after finishing chemo as well as before starting metabolic approach while NED ovarian cancer?
Okay, so a couple of things that we do. First of all, we do really comprehensive testing with LabCorp or some other reputable lab. So we do that first. And then if we're looking for specific cancer testing, so I have personally used RGCC for probably 12 years. And I know multiple other doctors there have also used RGCC. I did also experiment with Datar testing, which is a lab from India, but I don't feel like it is concurrent with what my findings are with RGCC. And then we also do molecular testing. So we use labs like Fulgent or Guardant or Tempus, different other kind of labs who look at the molecular targets that may be useful for a patient with cancer. And so we use as much testing as possible, but what I found after lots of use of these labs, I find like what really shows what works and what is relevant to the patient's diagnosis.
Great. Anybody in the panel want to add? Sean?
We all have our own opinions, and of course, you see six different practitioners, you get different reputations and answers. So, really at the end of the day, I think surveillance is really critical for ignoring cancer or some kind of thing. My suggestion is construct the following markers, always for stool and twin bladder, and then looking at circulating tumor cell activity is important. I think your NED anatomically on scan this, you may have any molecular so these files. So that'd be my field, the true observation point.
Thank you for that. Doctor, am I tested? You are right.
Do you want my mic?
So since you mentioned in your own presentation, you hit 50 and you got back into working out. So I'll say, can you recommend any anti-inflammatory diet, paleo, vegan, not vegan, to prevent lower risk of cancer recurrence?
Well, I think it's been said 2 or 3 times on the stage. I'm not a food prison type of practitioner. I believe that a lot of people that come to me are in a state of nutrient deficiency because they've been put on so many different regimens and diet. If we talk about the microbiome, there's actually no correlation between either a plant-based versus paleo in the change of microbiome. There's no true studies that have been to show that. So people try to correlate when people are doing high protein or carnivore that they're worried about microbiota diversity, and actually there's nothing to correlate that is true. So second, I do believe people need more protein at certain times and more vegetables at certain times, so I'll digress back to, it's really about what brings you joy. Whole food, organic, non-GMO, look at the markers, look at the blood, where are you deficient, how are you absorbing, how is your digestion, is there inflammation, candida, parasites, dysbiosis, all of those things matter. At the end of the day, people, unless you were eating, and this is nothing against fast food restaurants, but yes it is, unless you were eating the complete standard American diet and that is what brought you to your diagnosis, then you know that a change in nutrition, just going whole food organic, would be beneficial. Some people, I think, get to a state of disease, and I see this a lot in my practice, and they come in and they've tried every diet, every food restriction, every elimination, and really all it does is create more deficiency because they're not filling the gaps. If you choose vegan, because that's what your practitioner is recommending for you, make sure you do it well. You do it with complementary proteins, amino acids. If you do full carnivore or higher protein, make sure those sources are good as well. And I can't give a general statement on what you should or shouldn't eat, but for me, it's really about keeping the deficiency levels up and optimal, and what's actually doable, what you will do, what you can do, and what you can afford to do. So that's would be my opinion.
Dr. Devlin, if you want to read any of the questions. And again, if you have any questions, please submit them. Thank you.
If you guys have any questions you want to ask directly, that's great. Also, I do have a good question here. Pretty good recap, Erin, because
That's right. Pass it down.
Obviously, these are probably good questions from physicians. So, the first one is concerning methylene blue, specifically what is the role of methylene blue into active treatment or in remitting cancer patients? Does the exact immunotherapy to be effective? Does the type of administration matter for the cancer, or IV? And the question one is IV safe. So I think these are
We use quite a bit of methylene blue, so it has a number of different purposes. If you, for example, want to treat a specific cancer, we can do it a couple of different ways. If it's a very superficial cancer, I will use small amounts of methylene blue with a little bit of insulin and then actually inject it in around the tumor. And then we'll come after it with a laser and heat it up. We've also given it intravenously in an insulin potentiation situation, so we actually think some of that dye is getting to the tumor, and then we'll laser it as well, especially for deeper tumors. It's a photoactive substance. We use it also for, you can use it for brain issues if you want to take sublingual methylene blue or even the liposomal form, and then we have a headset, which is infrared light. So if you heat up your ears and inner ears, and it penetrates up to good 5 centimeters, you're actually doing some brain activation as well. So I think there's even some work to show improvement neurologically with that procedure. There's a lot of just prophylactic use. We have a little watch we actually put on our wrist, and we'll take 5 drops, wait 20 minutes, and then we'll wear the watch for 30 minutes because it photo activates through the blood. So again, it's what's the application? What are you trying to do with it? And it's unfortunate you don't always find measurable changes in just your day-to-day use of it, but people do feel better with it.
You feel like adding to that, or are you okay?
Well, no, I think the stacking of it with photodynamic therapy is the great therapy approach there, coupling it with that. And it is great for the brain. IVs, say, when dosed right.
I want to ask a question because all of this new information is coming out, so I'll ask you both where people are saying it's dangerous, that it's a chemical cleaner. Can you comment on that?
So a couple articles have been put out there about the grade. You want to get pharmaceutical grade. You probably want to spend some time looking. I wouldn't exactly just go to Amazon and buy anything that you actually find. So look around a little bit, maybe ask a doctor that does it. So I have 2 different forms of it that we use. They're actually kind of well vetted. We've used them for quite a bit and we kind of know the sources. There's a liposomal form and there's a nano-based form. So we use a little bit less of that. But spend a little more time getting good quality because you don't know really who the vendor is. And there is one out there that I don't know the name off the top of my head, but they are not using pharmaceutical grade. So,
Thank you, Juergen. And I have this is going to, so we spoke yesterday, I'll say you spoke yesterday about COVID-19 spike protein protection. Question, do nicotine patches help?
I've heard about that. Yes, there is some evidence that actually even nicotine and people and smokers are using nicotine patches. They find it is actually preventive of COVID, and actually, I think in long haulers they're using it as well. So,
Thank you.
I don't know the dose or the details. So,
Dr. Devlin. And if you have one for Dr. Connealy, is she still with us? Yeah, okay. Yep, you're right.
She actually published a study about the nicotine.
I don't know if it was a study or if it was just something that was touted during COVID by, I think it was Dr. Artis, who basically kind of got the research out there. And from what I understand, it blocks the receptor site that the spike protein can attach to. If you've never used nicotine, the patches or the gum are what he recommends. But I usually tell people half or quarter it. So if you have a patch, cut it in half. That way you're not getting that mass rush, especially if you've never used nicotine before. But, my belief is if God spoke it into existence at one point, there is a purpose and a use for it. I think how we have used nicotine over the years was not good, putting it through asbestos filters and smoking it and oxidizing it. But I think it has a place. And maybe for a time such as this, that's what it was created for. I don't know. So I have used it on a few people that had POTS associated with long haulers, and I believe that's a mast cell activation syndrome. But they were smokers. They quit after they had COVID. They were suffering massive long haulers. We were trying everything. I said, why don't we try this little patch? Her hesitation was that she didn't want to start smoking again. I said, well, I don't think that's what it's going to do. And it actually fixed her POTS. So that's just a testimony to that it can work. Do I have a clinical trial on it? No, I don't.
When you down Connealy, you'll find a variety of articles showing cross reactivity between nicotine and receptor site listing on receptor site and spike protein. There appears to be a lot of articles where this came from. So,
Devlin, thank you very much. Let me see here. Go for it.
Oh yeah. So this was a follow-up question. It'd be great to hear everyone's feedback on this. But what is the role of certainly tumor cell testing? How do you use it? How do you frame it per se in reference to how your patient's doing? Does zero really mean no cancer? This seems to be misunderstood by many patients. And what do you act on? What's that number?
So when you look at cancer, it's a 5 billion piece puzzle, and we can't look at one test and go, aha, we know what the picture is. Not only do we know what the picture is, we know what the cancer is doing. So I think we have to understand the context of what we're trying to evaluate. And this includes not just laboratory, this includes not just specialty testing, but also imaging and clinical exam, to be honest, bringing all of these data points together and saying, what does the predominant of the evidence tell us? I have seen patients, as I was talking with somebody earlier, with stage 4 breast cancer, normal CA15-3, 2729, and circulating tumor cells. And I've seen just the opposite. Stage 1 with what appears to be, CDCs 3-4, and elevated significantly in the hundreds of CA15-3, 2729 if we're talking about breast cancer. So we have to look at everything in context and then look at the predominance of the evidence. So if we see individual labs and imaging and 8 out of the 10 are trending the right direction, we're seeing tumor regression, we're seeing labs that are pointing the right direction, and understand we have to look at simple labs as well. Ferritin iron ratio, C-reactive protein, LDH, all of these can be beneficial. And then if we see 8 out of 10 going one way, we can take some confidence that we're moving the right direction or not based on that. And so that's where you get the science and then the art of medicine. The art is that creative application of it, which unfortunately has been lost a little bit. But I think when we bring that back in balance, that's how we better answer that question.
Thank you, and I have actually, and I so appreciate. Let me break this pile up. I'll give some back down to Dr. Devlin here. What's that?
Recording in progress.
They're listening.
Recording stopped.
the C, the ABCs, huh? Here's a question that came to me when I approached the stage, and I appreciate it. It says, why do we not see many case histories, treatments, outcomes, as well as statistics? Are there any specific cancers you wanted to cover, or are you just, what do you? Yeah.
We've actually looked at this. I think you were in those meetings several years ago in Reno, where we've actually had tried to get a prostate cancer study together, and the problem was that I think it just fizzled out. There isn't enough money, there isn't enough consistency in patients, and I don't know who is interested in low-dose chemo as a treatment option, even if it was that, or even did it with breast cancer. There's just not enough interest in it. But again, university studies lump people together, whether they actually fit together or not, I don't always agree, but we treat people on an individual basis. Right? So when we talk about outcomes, it's going to be based on that person on that individual basis. And no two people are treated the same way, even if they have similar disease. So it's going to be really hard to say, oh, we've got great outcomes, right? So we don't know what that means. So I would say on an individual basis, we could probably say, I can't give a number. I mean, I've been doing this for 20 years. I can't tell you to give a number. I got people that start, they're doing really well, and then they leave and go someplace else. And people do crazy things and they self-sabotage. And then you're back to square one, and then they don't do well. So where do we say, what's the determination of their success? It's on an individual basis. I don't think we're going to get some studies and statistics. That answers it.
You're right. We need outcome data, and I think we have an opportunity today with RFK and the reorganization of HHS. I think we have an opportunity to re-envision and restore a decentralized process that I think can open that opportunity. We absolutely need that data, but we need the money and we need the multi-center trial approach, and we need doctors that are interested in it. I mean, we have doctors up here that are interested in it, but we need more doctors so that when that opportunity comes up for bulk grants to actually do this, we say, we need you. If nobody signs up, then, it kind of falls flat, even though we have the money.
Great. A quick shout out to Dr. McLelland, who's up in Alaska, and he's not here with us. He's a phenomenal naturopath up there. He actually suspected myself and said he couldn't be well. So I'm going to try to get better speak to my lips in my mouth. Anyway, this next question is concerning next steps for a patient with glioblastoma. Patient is IDH wild type, and they have had 2 tumors. One is in the brainstem. No surgery there. They have had prior radiotherapy. Looks like Temodar as well as Avastin. And still taking their milligrams steroid daily. They also have a BRAF mutation. What sort of advice would you folks give about next steps for a patient in this situation? And knowing,
Tell him he's come. Everybody.
That's a tough one. There is a unique treatment that Dr. Todd Obakais, I don't know if you're familiar with him, he uses V cells. He's got 2 cases of resolved glioblastomas. So that would be the person to reach out to, and I think Dr. Ellenberg knows him. So that'd be good contact.
Okay, anybody else who really doesn't mind, obviously there's a lot of therapies out there, transcranial magnets, and these are also all considered palliative opportunities, and there's a device they can wear. It's something that requires a protein erosion, multi-therapy approach as well. So the fact that they're still around and can do well, obviously,
Dr. Ellenberg does have photodynamic therapy. He's quite familiar with those options. I don't know which is the best agent for GBM. I also use a lot of oxaloacetate. You can give it intravenously and take it orally, and also ketogenic diet. It's really crucial.
Moving on, with someone else can you add a question came from someone here for a lot of yeah.
I have a comment on the board.
Okay, that's good. Yeah, do you want to do a conversation of this? I'm going to go if you want. Or just setting out something up.
We've used that before as well, and there's been some success with that as well. There's one vendor that uses it, and it's a very easy powder to use. And gallium is an oral chemo, essentially, with minimal side effects.
So, it is a white powder. You take it once a day. You can't take it around anything acidic. You need a hemoglobin of 8 or above to use this product. You cannot be taking it if you're doing iron transfusions or taking iron, because it competes with iron. It's a light metal. It's on the periodic table next to zinc. And it's going to go down the same path as iron and attach to the transferrin receptor sites on the cancer cells. And it blocks DNA replication. So it basically will kill the cancer. We just had a study come back from a lady that came into my office, was a stage 4 metastatic. It started in her lungs. It went to her brain and her adrenals. 5 months later, she is now cancer-free. Okay, so.
Nice.
Yeah.
Yeah.
Gallium maltolate. Not just gallium, but gallium maltolate.
Thank you. And are you liking this hot seat type of Q&A?
Yeah.
Yeah. So
Nice.
please keep them coming here. Here's one. What would you suggest for someone whose body is burned by radiation of select tissues like colon, anal, as well as throat?
In the repair phase, we would do things like stem cells, exosomes, and even V cells. So if you're not familiar with the V cells, very small embryonic-like stem cells. They're actually in your blood. So we have a centrifuge that removes them, and then we photoactivate them, and then we put them back into the bloodstream, and then with the laser, we tell them where to go. So if you have injury to a certain part of your body, that would be the place to go. So we've seen it work really nicely on parts. We've seen it work on joints. So there's no reason why you wouldn't use it on other areas.
Maybe that'll help.
You could also do a BPC 157 internally, GHKCU, inflammation, TB 500. So it just depends on what the initial cancer was, but BPC is pretty safe overall.
So a question for providers, what learning sources do you recommend we can learn what treatments work best for all the different types of cancers? I understand metabolic dysfunction, but also each patient is different. I just go down rabbit holes. PubMed, I start there, EuroPMC, and there's a lot of great AI apps out there. Research Rabbit's something I used it in the presentation, and basically they just help to, there was a great study came out talking about AI, and the people that were using more AI, the less critically thinking ability that they had in certain characteristics that were described. But AI can be our friend and ally, can help us in efficiency. And so going down the rabbit hole of research, I think, is one way to do that. And so that's how I use it. And as doctors, from a patient's perspective, I think doctors, we have an obligation when we talk to patients about things, or if we post things online, blog posts, etc., put the references there. It's not obviously research, but it gives the ability to engage on the science. So as I was saying something earlier to a lady, so they can say, hey, I don't like his hair, I don't like his shirt, but he's got a study there, so I got to read it and engage on the science.
Just want to remind everybody and actually reassure you that we are recording all of the talks in our conference, and they are going to be available as videos on our website about a month after the conference. So if you're trying to write everything down and you feel like you've lost something, don't worry, because we will post all of the sessions. Thanks.
Well, there are actually, from regarding the question on coursework, there are a lot of things you can do online. So it depends upon what you're interested in. You're not going to get everything. There's just way too much out there to learn. Pick the areas that you're interested in, develop your treatment program, and you work your treatment program. And that means you develop it, because if you walk in with a little confidence in what you're doing, patients will understand that this is what works for them. If that resonates with them, then it's a good match. So I've done NET courses, and I've got to go to them and I look it up online and I go to the courses. I start working different things that I want to bring into my treatment program. I'll take a mistletoe course, right? Do I want to learn more about chemo? I'll take a course on chemo. So it's a matter of what you're trying to bring into your treatment plan. So individualize it. I do a lot of work with functional blood chemistry analysis. I've taken 2 courses on it. And then what I do is I layer myself. So I initially go in there, I learn the basics, I start applying the basics. Then I come back maybe a year later and I relearn it and I learn to the next level. And then I come back again and keep relearning and improving on this skill set as I develop other skills as well. So it takes time. You can't just wake up and get all this at one time. So it's going to take years of learning, implementation, seeing what works, seeing what doesn't work, figuring out and developing your treatment program. And that really does take time. But these places like this are great ways to get started, to start getting information and talking to people as to how they can either teach you or to actually help you, direct you to where to go.
And there's, just so you guys are aware, if you have the knowledge, you have the knowledge to question. You know, I think that's what happens. You walk into an office and they just scare you because you don't have a foundation. So like exactly what Dr. Winkler was saying, get the basics down. You know, I'm sure everybody here knows how to read a food label now, right? You didn't know that before, but all of a sudden you had to learn. You had to learn what those ingredients were. Thanks, food babe. So you learn from other sources. And like Dr. Winkler was saying, I teach functional blood work and I teach it to medical practitioners because they don't look at those ranges functionally. If you have a functional range in your blood work, you can see movement pretty quickly. If you're looking at normal ranges, you're waiting for trouble on very large, wide scales. Learn to read your blood work. Learn to understand what's in the medications they're giving you, how it's interacting with your body. Learn about your supplements. What are the herbs within them? What do they do? So start with those things. That way you have a base of understanding of what you're putting into your body, what the numbers that they're looking at, how you can better position your questions, not to go against the grain, but actually just to stand up and advocate for yourself. So very important things.
Thank you, Tracey. Hearing Dr. Winkler, but also being on the other side, I know Dr. Connealy's back, so I'll throw another one at you shortly. Being on the other side is caregiver for my wife. My wife's diagnosed. And you kind of go through panic education mode. You know, and this question is perfect for that. There's so much conflicting information and approaches in terms of supplements as well as treatments for cancer. What would you tell a family member how to choose the best approach? And I get that question a lot. What did you do? You know, and I tell everybody, you're going to be bombarded with everyone and their mother telling you, try this, try this, try this, try this. And they did that to me, to Corinne and I, and it just, you're kind of set back. And what I share with people now is, I hear the crocodile tears. What I share with people now, it's their journey. They're already scared as it is. And when everyone's coming at them, you should do this, you should do this, you're scared, you know, and that's why I call it panic education mode. You've been given a diagnosis. I don't think it's fair when you say, oh, you have a week. You know, my father-in-law had a week, and you know what? He lived 11 years. You know, so, and my wife was given a year and a half, and she had 4 months, so you don't know. So on that, with you following up with all the Gotcha. So I'm going to let Dr. Winkler, because of sharing his research, and then we'll throw the baton to
Well, I think in that scenario what you just described, that's not your thing to own. So give it to somebody else that knows what they're doing, all right? If my car breaks down, I'm the last guy I'm going to look under that hood, okay? I'm just not the guy. Don't call me, okay? So I know what I know, and I know what I don't know, and I know I don't know how to fix the car, so I don't bother. So don't put that onus on yourself. Find somebody who knows how to do that. I take a systems approach. Before I even see a patient, I'm looking at 5 balancing mechanisms of the body, all right? What's their pH? Okay, are they alkaline or are they acidic? How are they managing glucose? Are they glucogenic, ketogenic? How are their minerals? What's their mineral status? What's their sympathetic, parasympathetic balance in their body? When you're sick, you're sympathetic, or you've worn the system out, now you're parasympathetic. How does your body utilize oxygen? It's a crucial point. Cancer will disrupt that metabolism. So what state are they in? And then what's their emotional state? And do they, as a patient, actually want to hear anything you have to say, because they're the ones that have to do this. They have to own what they're going to do. So find somebody that does this. I have my staff purchased a cup that sits on my desk, and it says, "Do not confuse your Google search with my medical degree." And everybody stops and looks at that, and they laugh. And they go, "Good cup, that's good, I like that." You know, so I have little symbols around my office about things, but it is kind of, sarcasm is one of the advices we give around here, So it's just, you just have to kind of keep it a little bit lighthearted, but at the end of the day, I'm trying to treat that person on an individual basis, and it's not the caregiver's, spouse's ownership of that problem. And it's not anybody else's business to give unsolicited advice, because I only answer that question when somebody asks me. All right, my father-in-law had an illness, and everybody in the family was giving an opinion. And they finally goes, "Well, what does Juergen want? What does Juergen think?" I go, "Oh, you're asking me? You want my opinion?" Thanks. Listen to cardiologists. So, it was kind of one of those things. So you have to realize where the opinions are coming from. They're all well-meaning, but at the end of the day, the person with the problem has to figure out what they want to do.
Sure. You want to throw it at Dr. Connealy on the screen?
This is Dr. Devlin. Dr. Connealy, this is the question. What are your considerations when providing therapy for a patient diagnosed with sarcoma? It'd be nice to know what kind of sarcoma, but it's just sarcoma on the question right now. So thank you.
A little louder, please. It's on sarcoma. Say it in. More time, louder.
Dr. Connealy, did you hear that question that Dr. Devlin was sharing?
No, I didn't hear the question. Yeah, if you could repeat, that would be awesome.
The question from the audience is, what is the best therapy for sarcoma? No specific sarcoma is given. Just your opinion on how you address the sarcoma.
Best therapy for sarcoma.
Right. Yeah, so sarcoma, as mostly everyone knows, is a tumor of muscle and bone. And so, as with any cancer, cancer is a whole body system malfunction. And so, as Dr. Winkler was saying earlier, you've got to address every facet, whether it's the stress, the nervous system, the acidity of the body, the toxicity of the body, and all the abnormalities that you find on the blood test. And then typical treatment for sarcoma is basically surgery, and so removal of the tumor. And chemotherapy and radiation doesn't really help that much. Yes, doctors will use chemotherapy and radiation, but it isn't that effective. But repurposed drugs, a combination of repurposed drugs, is very helpful and effective, as well as creating healing of the terrain of the body. And so, and then the targeted supplements besides, using pancreatic enzymes and vitamin C and, sodium bicarb to alkalinize the body, and other targeted nutrients that might be beneficial, DCA, and, vitamin C, artesunate, all those different things, finding out what works. And that's kind of, with sarcoma, it's really trial and error. So
Awesome. Thank you so much. I think there's a little bit of segue, but I kind of wanted to ask these audience or reflex back to you guys. Anybody here watched the Netflix special called Appleseed? Do any of you have comments? I would certainly love to hear your feedback on it. It's something that I have mixed feelings about myself, and maybe we'll even ask some of the attendees who may have watched it. Those who have watched it will make a comment on Appleseed vendor. I think it's very pertinent to what we're actually talking about today.
Yep, if you had a mic.
Unfortunately.
You know who you're talking to? Oh my God. Well, I was intrigued by the name, the title, because I drink apple cider vinegar every day, so I had to watch this series. But what bothered me about the messaging that I think came from the series was that it made it sound like all the alternative stuff, even though this woman was touting it based on a lie about her own diagnosis, she didn't actually have breast cancer. But it still gave the spin to me at the end of the day with the show, is that the alternative stuff is a lot of, hocus pocus, and you always have to fall back on the conventional stuff. So that just bothered me about it. I think the message wasn't great. Obviously, the fact that this woman was lying about her own condition to vulnerable people was very upsetting. I just didn't like the way they spun it at the end of it.
So if anybody has had the opportunity to watch this series, I think it's very worthwhile. It hit me both ways, and the person I got when I finished it, I was in the mindset of how heartbreaking this situation is, right? And I recognize my patients and the characters that were portrayed in the show, and what I realized was my patients can be victimized over and over and over again, not only by the traditional ontological approach, but also by our quote-unquote friends and family in the medical movement or functional oncology movement. And it's just a travesty, right? And the sad part is I have to battle this every day with my patients because they come to me with Christmas cancer. I said, man, I have breast cancer. I have to live with it. So God bless her, I'm happy. Right? Or Nation had this issue with insulin overcoming, and we don't have any just those years with brain cancer. So I think it's very hard for us to grasp and understand the mission walking issues of cancer patient, what they're facing, not only from traditional oncologists, but also from integrated practitioners, right? And there's some really wholesome, strong, educated practitioners that are doing the best they can with the tools we have in integrated oncology. But there are people who are simple cultural results, right? These are people who are out there manipulating, control, and take advantage of folks. And the last thing we want to do is spend or invest more on processes and procedures that deal with that. And I think that's one of the battles I always fight, certainly internally when I recommend those people, but also with the other party when I see this perspective. So if you haven't watched it, please watch it. If you want to watch the actual live, but that'll give some people perspective.
And what was the name of the movie again?
It's Apple Cider Vinegar.
On Netflix, huh?
I don't believe in coincidences. So that type of publication, I think, has a purpose. And I think we have to understand where we may be critical of those in the conventional oncology world. We can't fall trapped to the same processes that they do, where they do protocols and now we do protocols. We're just doing more natural, more integrative. We have to really be precise in what we approach, whether that be genomics, epigenomics, transcriptomics, on and on. And we also have to understand what we're in. I mean, this is a platform. This is a game, if you will, where there are those that have controlled who has picked the winners and losers, who has picked the team players. And so we as integrated practitioners are now coming in to say, no, we want to pick our own players. We want to play this game a slightly different way. And so we have to recognize there is a battle for the narrative. And these subtle things, I don't believe are just subtle. They are a battle to control the narrative. And so I think it's very important when we recognize the words we use. That's why I don't like the word alternative. I think that's a word simply to marginalize. And so let's engage on it and say, okay, no, what we're doing is we're actually using this therapy because there's these studies that show here's how it works, here's how it's acting, here's what it's targeting, and I'd love to engage with you on the science. So by doing that with our colleagues in the conventional cancer world, we're providing an open door to reach across that aisle, engage in the science, and then actually hopefully find where we can agree and where we don't, and not create enemies. What I say are just unforced errors. If we create unforced errors, they have the predominant of the money, and they can actually use that to control that narrative.
Thank you. Thank you. Thank you for the questions. First off, everyone. I know you're incorporating ivermectin, Dr. Winkler, so I'll throw this at you. What's your opinion on ivermectin, mebendazole in combination with standard care of chemo pills for kidney cancer?
I'm going to answer this in light of, I'll answer this in light of actually Jane McLelland, because I think she taught some of this the other night on the workshop. She uses AI, perplexity.ai, and that's where she would ask those questions. Like, what's the best cancer? What's the best treatment for cancer? What's the best repurposed medications for cancer? What are the active pathways in my cancer? Is it fat? Is it glutamine? Is it glucose? I think she had a whole list, and I actually typed them all out. There's at least 15 questions that she asked through AI that will actually answer what is the best thing to use. There's a couple other physicians. I look at a lot of Mitch Gann's work, and he's done a lot of work with repurposed medications. He has a whole protocol for kidney cancer. I don't have it off the top of my head. So there's a lot of information that's out there. I think you just have to spend the time learning and figuring out what's active in your body. So what are the biomarkers? What's going on in your physiology? What's the right medication or supplement or whatever that you want to use to offset that, and actually then see if it works or not. So I'm just not I don't really shoot from the hip on those types of questions.
Yeah, I think there are two flagships when you look at integrative oncology. One, vitamin C. Two, repurposed medications. And so I think those, when you look at those therapies from a conventional cancer world, they look at those therapies and they go, they're integrative. And so we have to recognize that we need to know the science there. We need to defend it. We need to call out where there's not good science there that's been advocated for. But with repurposed medications, of course, ivermectin, and I jokingly called it a profane word because, I've been given ivermectin for cancer since 2017, and all of a sudden it became something that couldn't use. And I knew it was safe, but it's not without side effects. Now, I think the mebendazole question is a real good one. And ivermectin, we have to use that. Again, with repurposed medications, there's a lot of protocols, and protocols are good, but we can't just treat everybody like a protocol. And we have to recognize when we're using ivermectin and other repurposed medications or any therapy, let's try to target. Let's try to be precise in what we're doing. Mebendazole is a great question. There's a lot of, talking about Dr. Google, what do you call it, Dr. Social Media? Go in social media in the comments and see what you see. It's scary. It's scary. But, so there's a lot of people that talk about fenbendazole, a lot of people so I'm just going to go there. It's a benzimidazole. But when you look at the in vitro studies that we have, there's very few, but we have, they show that mebendazole is the better microtubule disruptor. And we have studies that give us better guidance on how to dose it, how to provide human equivalent dosing, what the toxicity profile looks like. Fenbendazole, yeah, not much of anything. Now, might that change? Yeah, but that's just where science is. So when we're going to dose something like mebendazole, same way with ivermectin, target it, bring the focus to the treatment, not a protocol, but let's be honest in the integrative space and not just do something that's different just to be different. We don't have to be different in integrative medicine, just follow the science. The science will lead us to the integrative therapies that are going to work.
Yeah, Dr. Connealy. Yeah, Dr. Connealy, can you hear me?
Yes, I can hear you.
Awesome.
Everybody always asks about what about this, what about that? Unfortunately, like a lot of the speakers know that there's hundreds of things to target cancer, fight cancer, and interfere with the cycle of cancer. And ivermectin is one of them, and it's been in the news lately because Mel Gibson talked about several of his friends using repurposed drugs and surviving stage 4 cancer. And, we've been using repurposed drugs for a very long time because, one, we address the parasites in people. And so ivermectin is one of many drugs, as well as albendazole, mebendazole, bembendazole, and many other drugs, niclosamide, et cetera. So it's something we've been utilizing, but none of us have a one size fits all. And so you've got to you have to develop as many healing pathways as possible. And repurposed drugs are just one of them. And then you've got to make sure you monitor the patient's blood, make sure their liver function tests don't become elevated, and really watch the patient closely to see what is really happening. Are you getting better? Is the patient getting better with their scans and so forth? And so again, there's just no panacea for any one substance. It's really developing the best cocktail of all the repurposed drugs, chemotherapy, whatever it is, that can help the patient heal.
Awesome. Thank you so much. I guess, just so you guys can hear me, we have, about half an hour left?
Exactly half hour.
Yeah, because we literally have some really great questions in here, and I hate to be triaging them, but I kind of have to. I'll move on, and I guess anybody that wants to tug on this one. This one's pretty specific. This person's concerned about treatments that we might recommend or consider for papillary thyroid cancer, stage 4 with BRCA and TRET gene mutations. Does anyone have any specific thoughts on that diagnosis? Bueller? Anyone?
Well, I'm a foundations girl, so first, obviously, we want to make sure her levels are with her most minute blood markers to make sure that her iodine's good, her B vitamins, all of the things, inflammatory process. As for treatments, I'm more of a conservative when it comes to any type of chemotherapy or anything like that, but I will refer out if needed. Otherwise, I'm going to pass it to Juergen because I know he probably has some magic. Oh, we're giving it. You know what? Why don't you answer that?
Oh, yeah. So certainly there are targets there available for treatment, but again, this goes back as an integrative oncology guy. I need to know more about the case, right? Mm-hmm. So ultimately, if you had papillary thyroid cancer and it spread, this is something that you're collaborating with a neuroendocrinologist as well as with someone who does oncology. Ultimately, there's a variety of tools that can be used, including potentially radiotherapy, immunotherapy, even chemotherapy in some cases. But ultimately, this is a challenging diagnosis. But I think if you guys want more specific information, we had to sit down in person with you and review basically medical records. So at the end of the day, this is another really good question, if you don't mind me going to it. Basically, a survivor is asking about how to maintain survivability. One of the more confusing indicators is what's considered a tumor burden. Looking at a Garden 360 result, when the results indicate a biomarker increasing, but not a major increase, could it be possible to target a particular marker with either peptide therapy or something else? I just don't want to overreact, and I think that's a good statement. Just one piece of information. P.S. Something will be done. Biomarker TP53 was. So a lot of times on these gardens, you'll see these TP53 mutations. Simply, it means it's a non-wild type TP53. So that braking system that normally is in place is broken. And right now, we don't have any wonderful targets. Experimentally, they have some targets, but nothing specifically to target that TP53 mutation. Anyone else here have any comments looking at Garden 360s and what an increasing ctDNA count looks like?
Yeah, I think you have to be, cognizant of that test, and they will bounce around a little bit. That's present 60 to 70%, and so what you're looking at there's something growing or something that's active somewhere. And one of the best places to be is NED, and that's one of the hardest places to be. So even though you may have a slight increase in that TP53 expression, it gives you the opportunity to target that. There are limited therapeutics out there. There's limited science to guide us on that. Vitamin C can target that. We don't know how well that's going to be effective, but there are there are studies out there, limited in vitro mostly, that will look at more natural therapies to target that. But in the end, you don't want to overact, and I think that's a good point, but I think it's the opportunity to work on something that at current is not growing in terms of a mass that you can see, and so you can actually work on things kind of underneath the radar, and you can work on things orally, work on things with nutrition, and probably take a more gentle approach, and then of course follow up with that, and use other labs to guide you on that, because if your ferritin's elevated, you need to bring that down. Vitamin D is 39, you need to bring that up. So it gives you the opportunity to add these other things in and give yourself time to affect change, and then follow those trends.
Dr. Connealy has something to say on this.
Yeah, so, we were using IV McLelland for the P53 mutation. Unfortunately, we're not able to get that any longer. We've kind of almost exhausted our supply of that. But I know there's a doctor who I have met who also is developing gene therapies that can also address P53 mutation as well as other mutations. So I think that is going to be the future eventually once they, I think, work out all the kinks and get it more fine-tuned.
Okay, thank you for that.
We have a question from someone in the audience who didn't really want to come up, but she's lovely. And she wanted to ask, with stage 4 pancreatic cancer, when chemotherapy has not worked, she's at the end of her course, what would you recommend next for her?
A little bit more information would be helpful, obviously, but looking at what kind of genomics, transcriptomics are out there. Is this a KRAS G12D mutation that's present? Can we target that? It is. Okay, so this is one of the upsides of being in Mexico, where we do the therapies. We have access to therapeutics that aren't approved yet in the US, but are approved by the Mexican FDA, and we can specifically target a KRAS G12D. It's a particular mutation that's present in about 35% of pancreatic cancers. I'm probably assuming there's liver metastasis as well, and so that makes it very easily targetable intratumorally and via ablation, as well as intratumoral immunotherapy. Of course, we can apply some of that chemotherapy intratumorally, like cisplatin there. I'm assuming they probably have FOLFOX, FOLFIRINOX. If they've been on Gemzar Abraxane, my encouragement there would be to add vitamin C in. The study out of Iowa talking about how that doubled the overall survival and so we doubled the overall survival and increased progression-free survival at 1 year. So there's lots of therapeutics available, and there's lots of approaches available. And the way I look at it is one of the major mutations there, a part of that cancer hasn't even been targeted.
So this is what we call hope and healing, which is what the Appleseed project is all about. And I'm going to introduce you to her after the panel, if you wouldn't mind. Sidebar.
Thank you.
Thank you for that.
If you don't feel like coming up, raise your hand to Julia. Julia can ask those questions for you. I'm going to go right down. I know we have about 20 minutes here. So have you seen long-term remission of stage 4 stomach cancer? If so, what was the treatment? You or Dr.
Connealy wanted to add a note.
Oh, sorry. We're about the pancreatic cancer question? You're on, Dr. Connealy.
Yeah, so it's interesting. I do have a patient who has and had actually stomach cancer. She was successfully treated with chemotherapy, and she is still alive today. And I told her she's a miracle because most people, they get either a complete body stomach resection or partial resection. And she successfully was treated with chemotherapy, and I regularly see her probably every 3 months. And the only problem we've developed recently is a little bit of gastroparesis, not complete, but there is a little gastroparesis. But she and her oncologist say that she's really a miracle. So she's very diligent about everything, following every single thing to do and really has mastered her self-care, but she's probably 3 years out, which is unheard of for stomach cancer. And we do everything from aloe vera to repurposed drugs to systemic enzymes to everything you can think of. But she is alive and well and functioning pretty well every day.
Thank you. Here's a radiation question, and actually they both came in around the same time. If you've had radiation in the past, can you have radiation again for a different cancer? And then another one that just came in at the same time, if you had radiation for breast cancer, can you have radiation again for recurrence?
Yeah, so that's complicated without more specifics. It depends on where the recurrence is at, obviously. If you have a recurrence in the bone that has been radiated before, depends on what their lifetime gray dose is, right? So if it's too high, then we try to avoid that if possible. That would be my opinion on it. But I think an underutilized therapy that's certainly out there that can certainly prime the pump is hyperthermia, whether it's local, regional, or whole body. I think there's a role for that with some of these recurrences, and patients seem to do better, especially if they become resistant to certain chemos or immunotherapies. We think there's a there.
Thank you. And I know my list is dwindling. Do you want to? And yours is filling out.
This one's. I tried to screen them a little bit, and sorry about that because it gets me involved. But this one is pretty interesting because I hear this all the time. What is your opinion on biopsies? Does it make cancer spread when you obtain a biopsy? Yeah, my answer is not enough data out there to suggest that it spreads cancer. I think that the only caveat that I know of is when they did morselization of endometrial carcinoma, and I think Nathan could speak of that. But as a former OB-GYN, there was a time when the oncologists used to go in and they would morselize these uteruses, and they would spread disease everywhere because their biopsy didn't capture the disease at the time and thought it was safe to do that, and it was not safe. And I've taken care of patients over time that were subject to that, and some of them died from that. Right.
Yeah, it's sad because you would see those tumors show up at the site where they would pull it out of the abdomen through the laparoscopic site, and that was a horrible surgery. We're sitting there. I can remember as a resident watching that be done, thinking, "That's a fibroid. Have we biopsied that? I know it's a rare risk that might be a sarcoma, but what if? What if?" But when you look at it depends on what kind of biopsy you're talking about. It's very low grade. I think a bigger issue is local seeding, local recurrence is a bigger issue because the process of metastasis, at least speculated via mathematical models, it's very low. It's very low, and it doesn't stand alone. This process, it requires everything to be in place, which is immune system, platelets, the aggregation, the distant site being prepared. So I think the bigger issue, and this is where you see it too with biopsies, you see local recurrences. And I think that's the biggest issue that we have to concern ourselves with, but that there is probably even low. But the question there is, what kind of biopsy? Is it a fine needle? Is it a core biopsy? I think all of these things play a factor.
If it's something superficial, such as a breast biopsy, we found that if the same day we do an ozone injection around that site where they have the biopsy, and then we give them a high-dose vitamin C infusion, and of course the next thing we're working on getting therapy, you get a lot of information out of a biopsy. And is it really worth not getting that information over spreading some cells that you can actually take care of immediately? Again, it depends on the biopsy. I mean, if it's your pancreas, it's a little hard, right? So
recording
I think
stopped.
there are ways in which you can try to mitigate some of the potential side effects or spreading of disease if we do it correctly.
Probably not going to get to all these.
No, I'm going to get to these. So. Here we go. How do you treat a patient? How do you treat a patient to help prevent recurrence of ovarian metastatic cancer? Ovarian metastatic cancer. So how do you treat a patient to help prevent recurrence of ovarian metastatic cancer?
No, I mean, a lot of times, I think it's from my philosophy around somebody who you get into either, anatomical NED is one thing, but anatomical and ctDNA not being present on follow-up exams. If they truly are NED, my recommendation is to continue on with the care. I do fractionated chemotherapy a lot, so I'll recommend that they double up the amount of time it took for them to get to NED to continue care, and it gets spaced out further and further. I think some of my other colleagues may have a similar idea, but we believe that keeps you from having a near time or near temporal recurrence. That's been my experience.
There's a lot of different answers to that question. So yeah, Dr. Donato would actually, a Mexican physician that trained both of us, he would actually do one additional low-dose chemo treatment for about a year after. There's a lot, I spend a lot of time on this area. A lot of patients come in this way. So we spend time looking at circulating tumor DNA. So it's like a Natera test. We do RGCC, looking for circulating stem cells and cancer cells. And then we develop therapy off of that. We look at copper levels in ceruloplasmin, looking for free copper. We do some copper lowering. We look at other inflammatory markers. We look at galactin-3, whatever other inflammatory markers. And of course, going back to the terrain, what's going on in the microbiome, what's the diet like, what's nutritional status, and then we do a lot of detox at this level. People are NAD. I tell them, hey, I'm really glad you're NAD, but now the work starts.
Yeah, I think this is it. I'd be interested to hear y'all's take on this, because when you look at full dose chemo, of course, it's directly cytotoxic via a variety of mechanisms, but it's also inducing a lot of, senescence. And that process of senescence is a byproduct of low dose metronomic chemo as well. And so when you have a senescent cell that you produced, that's not necessarily just cancer, it's also senescent cell of healthy cells. So it could be immunosenescence. And senescent cells are cells that don't replicate, but they're metabolically active, producing things like interleukin-1, interleukin-6, interleukin-8. These are cytokines that can create an environment that's very pro-growth. And there was actually some animal studies that was very interesting, where they actually injected into mice non-senescent cells, and of course there was no growth. But then they injected senescent cells, non-senescent, regular cancer cells it grew, but a little bit. But then they injected non-senescent cells, there was no growth. But then they injected both, and the growth was double than just the regular cancer cells. So the point is, there's something about the senescent cells that are driving this process of recurrence, whether it be full-dose chemo, low-dose metronomic chemo. And this is where the process of senolytics, which is looking at this process of bringing senolytics alongside, I think, things like full-dose chemo, targeted therapies, or even low-dose metronomic chemo, and really providing a better long-term solution. Of course, senolytics would be like dasatinib and quercetin and many others.
Next question, I'm going to go right through these things. Lymph node under the arm recurrence. Is lymph node under arm recurrence in breast cancer and right breast considered stage 4? So is lymph node under the arm recurrence and breast cancer and right breast, is that considered stage 4?
No.
Yeah, no.
Oh, sorry, guys.
Yeah. Anything else yet on there? That's it?
One more time, sorry, that's all I have here.
Oh,
Is lymph node under arm recurrence in breast cancer and right breast considered stage 4?
Well, anytime you restage somebody, I mean, it would be whatever stage they had been at, and the chances are that is it truly a recurrence, or is it incompletely treated disease? What's the time frame? I mean, there's a lot of caveats to that, but yeah, probably 3A to C.
Okay. Here's one for Dr. Devlin here.
Dr. Jen, come up to the mic.
I can't see you over there.
Yeah. Her nickname's now Firefly. Get up here.
Come on up here. Come on up here. Sit here. Here.
Hi.
Right there.
I'm fine.
Break up the sheet.
Okay.
Yeah, just come on.
Okay.
I know
So
I
the
get
relevant
up here.
question there is if it's same side or other side.
Yeah.
So if it's the same side, it would not be considered metastatic disease. And if it's the contralateral side, then it would be considered stage 4 and metastatic disease.
Do you want to repeat that? I know it's a little.
Providing it's not a new primary.
What?
Providing it's not a new primary.
I mean, even if it's a new primary, if it's an axillary primary, it wouldn't be considered metastatic disease, right? Because the truth is that when we see disease that starts in the axilla, it's not really disease that's starting in the axilla. You can almost always identify the primary in the breast. Yeah, de novo axillary disease is exceptionally rare.
And I do love that dress, by the way. It was a compliment, by the way.
I took it as
Okay,
one,
good.
so you know.
Give
Even
her the
if
rest
you
of the
didn't mean it
questions
as
now.
one, I took it as
Yeah.
one.
Yeah.
So when you restage, what would you call that?
So it depends if it's the same side, then you just look at the degree to which the axilla is involved. So if it's 1 to 3 nodes with no extranodal extension, that's going to be a stage 2. If it's more than 3 nodes, so 4 nodes or up, or extranodal extension, then it's going to be a stage 3.
You want one for you?
Sure.
RGCC versus Datar.
So my grandmother used to tell me, if you don't have anything nice to say, keep your effing mouth shut. So, no, I think I mean, this is a good question. I've been asked by lots of people, and at the end of the day, I've used all these different labs, and I've had a variety of experiences. And I just say that I advocate for replicatable, reliable, and consistent labs that resonate with the science as it stands in 2025.
Thank you. My grandmother said.
Yeah. No, I would say at this stage of the game, I probably would lean in to Datar. I think Datar has some really good backers. It has some good science, and I think what they're doing is starting to break some ground in an area that I wish was around 20 years ago. So.
I know they're probably not going to like this, but on July 24th, 2017, we received our results from RGCC. That was the only time during Corinne's, I guess, journey that we had positive news. It was incorrect. Okay, so that was, it said we had no cancer and 0 cancer. And the joy that we had, we were in Mexico, and I'll share our journey down in Mexico, but our doctor was like, oh my gosh, I need to know that. And I don't want to throw anybody under the bus because, but it was really disappointing to have that news. And I was new, and I don't know that other test. But for us, that's what happened in our journey. So, but I don't want to take, and I know they've helped a lot of other people. I'm just sharing personal experience up here. So, you have any more down there?
Dude, I have so many. So, this is actually an interesting one. It's concerning the treatments that increase oxygen in the body. Reflectively looking at IVC, high dose, ozone, hyperbaric oxygen, methylene blue, and recommended for the presence of the FGFR gene. It might be EGFR, but if it's FGFR gene mutation. But at the end of the day, what are you guys' thoughts about using therapies that increase oxygen in the body? Anybody?
I love them. I think, we know the Nobel Peace Prize winner, that's what he said, right? Oxygen, cancer can't survive in an oxygenated environment. I think we're very deoxygenated as a society. We're exposed to many chemicals. We don't have optimal levels of nutrients that provide oxygenation. Some of my favorite things to do that besides complementary modalities is dimethylglycine. I love DMG. I think it's a great oxygenator. It's a great methylator. So there's lots of things you can do, but I do think complementary modalities, when placed at the right time, for the right person, for the right amount, are good. So.
Don't forget hyperthermia there. That's going to be an oxygen increasing delivery method as well.
And movement.
Yeah. Don't forget, that's the cheapest thing you can
In movement, it's the cheapest one, yeah.
So it was funny because patients always say, I said, what's the best thing I could do for my cancer that doesn't cost anything? One is fasting, and the other is move your booty. So, yeah. And the funny thing is exercise oncology, I believe they're even trying to create a fellowship in exercise oncology so that you can actually go and train to learn how to teach people how to train during the time they have cancer. And it's one of the best times in your life to sort of pick up a barbell, start moving your body, running, dancing, all that sort of stuff. Having that increased aerobic capacity can save your life. So that's great.
Even walking a mile a week, which I am not advocating for only walking a mile a week. But even walking a mile a week increases survival by 40%. And that's nothing. So movement is, not only does it increase oxygenation, but it also increases circulation, it increases lymphatic flow, and you can take all the supplements in the world, but if they don't get to where you need them to get to, they're not going to help you. You can do all the deep breathing in the world, but if you're not moving your body and you're not increasing your circulation, it's not going to help you. And so movement, I think, is one of the most important things that you can do before, during, and after your cancer journey.
Thank you. Go for it, Sean.
Amen. What is the current thinking about intermittent androgen deprivation therapy? So I'm presuming they're thinking about Lupron or Xtandi or Casodex or something like pulsed or alternated.
Sure, Dr. Kern?
The only protocol I'm aware of is with prostate cancer is to do 6 months on, 6 months off with testosterone. So you're doing androgen for 6 months, stop it for 6 months, along with doing other therapies. Again, it's not an isolated treatment, but there is some benefit to that.
Great. So this one's an interesting one. So this is concerning chronic fatigue. I'm not sure if it's related to their cancer, just underlying diagnosis. What is the recommendation for preventative care when exercise is a challenge? What do you do for chronic fatigue syndrome?
So it depends on what the SOS is. That is determined your chronic fatigue syndrome. Usually that's at the core of mitochondrial issue. We're not producing enough ATP to regenerate the cells. So my first thing is that we look at exercise wrong. We look at it as a way to burn calories, or, somehow it's a vanity play. But really what it is detoxification of the body. And, there's a lot of people that I see, and I agree you should be exercising, but a lot of people come in so depleted. So when you have chronic fatigue, the very first thing that I would say is put in the rejuvenation nutrients and or peptides that you need to activate the mitochondria so that you can recover. Exercise is not about doing. We all could walk out of this building probably and run 5 miles if we had to, right? But could you recover from it? You could. Like if someone was chasing you, like Michael Myers, I could run and fast. But the next day I may not be able to walk. So it's really your potential of recovery from everything. And that's really what chronic fatigue syndrome is, where you can't recover from these workouts. So again, you can do supplementation, things like CoQ10, resveratrol, all these things that are going to help with energy production. Dimethylglycine is a big go-to for me with that. As for peptides, you could look at MOTC, you could look at BPC 157. So those are things that I would recommend. And to make sure that your B vitamins are optimal, also reducing inflammatory foods. I mean, there's 100 different ways we could go with chronic fatigue. And then don't get me started on the emotional connection to it. We'll just save that one.
John, Dr. Connealy has a response.
Yes.
Yeah.
Dr. Connealy.
So, this is a common problem in patients. And what I usually do at the clinic when I see people who have lost a lot of weight and they have sarcopenia, I will have them do turbosonic, which is a vibration plate. But also, we also try to teach the patients, laying in bed, how to exercise, chair exercise, just stand and hold on to a table or a desk. Any kind of movement, like Dr. Simmons says, exercise reduces cancer, they say like 60%. So the biggest problem, I think, is people aren't mobilizing their 800 muscles. And so, if you can teach them any kind of thing, I mean, I usually in the exam room teach them, or one of our staff will teach them how to do things. Any little thing is better than laying in a bed or just sitting. So to incorporate movement. And sometimes people can, if they have chronic fatigue, I say start with 5 minutes an hour. And 5 minutes an hour, you're going to get 45 minutes in a day. And so, but people can lay in bed and exercise. Okay, there's lots of little things you can do laying in bed. And there's, like I said, the chair, just any kind of movement. And then we always use the turbosonic, and we also have a device called Juergen. So if they can't, but most of the patients can do some kind of movement, and some is better than none.
Perfect, thank you. And I know we're coming to the end here. Movement is very important. Vitamin D, oxygen, love, hope, don't give up. And you're surrounded by wonderful people, not only at home, most everybody is, but also in here. So if you have questions, want some support, this is what we're here for. We handpick our presenters, and I hope you're as proud of them as I am. Thank you for being up here. A question also came in about our exhibitors. You know, we handpick our exhibitors. We decline a lot of people that want to be here. So we do our background on our exhibitors as well, and not only on our exhibitors, but as well as our presenters as
So
well.
what do you think about holding on to all these questions, and then you and I can do a little podcast at some point in the future with a couple of our doctors, and we can answer the rest of the questions? Wouldn't that be fun?
Or we could stay. I know there was a CBD question about hot flashes, if someone wants to find me about on that one there. And then mistletoe question. I know Dr. Marolia was here, and I don't see him. But if you want to ask Dr. Marolia, who does specialize in that as well.
That one's left
But I
on my
thank
hand.
you. Oh,
Yes, the one.
it's the other.
Sorry, where can I get some?
Okay, and then Dr. Marolia will also be on a panel tomorrow who can ask. We'll make sure that question is asked her as well. And can we get a, yes? One more time, sorry. Gotcha, okay. So are we getting kicked off the stage, Julia?
Tell their stories.
Hello, Julia, one more, are we getting kicked off stage? Dr. Sam, can we get a picture here? Can we grab a picture with all? And thank you, audience, for this segment as well.